Dr. John Barbieri, a dermatologist at Brigham and Women's Hospital in Boston, Massachusetts. At the American Academy of Dermatology meeting, I've given some lectures on cost-effective care for acne. This one focuses around really how to optimize providing high-value care for individuals with acne. And one of the first things we can do is when we're doing topical therapy, where we so often need multimodal treatments that are going to address different pathogenic factors in acne, we have a lot of great fixed dose combination products now that we know are associated with better adherence and better outcomes, and they're very low cost. In fact, they often cost less than having two individual single agent products. So really taking advantage of these fixed dose combination products like adapalene benzoyl peroxide, clindamycin benzoyl peroxide, and clindamycin tretinoin, which are all generic products in many regions and very affordable in many regions, can be a great way to improve outcomes and adherence when we're using topical therapies. As I mentioned, spironolactone can be a great systemic treatment for acne. So for those with more moderate to severe acne, very inexpensive, very effective treatment, very well tolerated. In the SAFA trial, about 97% of people were able to tolerate 100 milligrams a day going up to that dose. So we know that this can work really well and that many patients will not have any major side effects from it. So a great option. Combined oral contraceptives, another really cost-effective, great option for our female patients with acne. Some data suggests these can work as well as oral antibiotics again. So another really nice thing that we can use for our patients with acne. And then when it comes to spironolactone, we talked about reducing our lab monitoring there, but with isotretinoin, there are also opportunities to improve our lab monitoring. There's really not compelling evidence that lab monitoring provides much value at all, and certainly limiting lab monitoring to a baseline and maybe a peak dose of things like checking an ALT and lipids or triglycerides, that's a reasonable practice. And honestly, I would argue that the lack of evidence of being able to detect or prevent pancreatitis with lipid panels, lack of evidence of anybody getting meaningful liver injury really kind of suggests that this lab monitoring we're doing may have very minimal value. We're checking labs, but it's not actually helping us guide management. And if it's not helping us guide dosing or help prevent some kind of rare adverse event, why are we doing it? And so I do think there's an argument to be made for reducing our lab monitoring even further in some patients and considering no lab monitoring for those who understand the risks and benefits of lab monitoring.